and nervous, a little bit nervous with south wind. I think that in Turkey is the same, that you have problems with the south wind. Özlem.
Well, in Istanbul, there's no problem, but the south part with between the Syria and Turkey, there is a border, and as you may remember, there had been an earthquake there,
Yep.
and two big earthquakes, and the buildings were not so made good enough. And that's why lots of people are lost. In Hatay University, it is just on the middle of the earthquakes. The rectorate just reported today that 100 students is lost. Some of them died, and some couldn't find where are they, not with their families, not as find the bodies, and so that's terrible. Yes, there's a big problem at the Syrian and Turkey border, 11 cities, and bad, so bad, terrible.
And you have earthquakes every day, every few hours they have earthquakes. I have application, and that application can show you when and where is earthquake. And as I can see, they have every few hours they have small earthquake.
And also the problem is, Tanya, if the building is just tired of the earthquake shakes, although the other shakes are much more lesser, as the building is tired, it just collapses.
Yeah.
It doesn't matter if it is made good or bad, and this just comes another problem.
But it's problem of bad buildings actually because of corruption, because you have, as in former Yugoslavia, you also have, I think that you have a law in which way you have to build buildings to don't be destroyed during the earthquake. So some of buildings are not destroyed because of good way of building.
Yeah.
Amanda, we're ready to start if you want to. Go ahead.
Oh, am I sharing?
Yeah, if you don't mind sharing, and then seeing that I'm presenting, I think it'll be better managed.
Okay. And Mercy is joining us?
Yes, I'll just send a message to reminder.
Okay. Well, so good day, colleagues. Good afternoon. So far we are only 6. So you know me, I am Amanda Howe, GP from UK and previous WONCA president, still involved with this SIG, of course, as co-chair with Shabir. Shabir is presenting today, and also his colleague Mercy from Kenya. And we're particularly using the examples from these 2 African settings and the work they've been doing together to give an example of advocacy. We had a seminar this morning as well with about the same numbers so far for people in another time zone. I think we have time very briefly just to let colleagues tell us who they are and which country they are from. So, Özlem, would you like to go first?
Well, thank you very much. I was just trying to change my background because lots of bad things are happening in my country today. I am from Turkey, and I am working in Izmir. The earthquakes didn't shocked us this year because I was in Izmir, but in the south part between the Syrian and the Turkish border, there had been a terrible earthquake. I am working in Izmir University of Economics at Faculty of Medicine, and I am working as a family physician there. Also, I had my PhD about physiology. Thank you very much.
Thank you. Tanya, would you like to go next, please?
Hello, I'm Tanya Pekes from Croatia, but born in Bosnia and Herzegovina, with a good connection in all parts of former Yugoslavia, working in rural area 70 kilometers far away from Zagreb. I'm lecturer for nurses on the University North in Varaždin, and working on my PhD thesis about OECD quality indicators for primary care.
Excellent. Thank you. Good luck with that.
Thank you.
Now, April, bravo.
Hi, everyone. Thank you. My name is April Prabowo. I'm from Indonesia, and I'm currently working as an academic physician at Universitas Muhammadiyah Yogyakarta. In addition to that, I'm also a founder and director of Catalyst Institute, a nonprofit organization for primary healthcare advancement in Indonesia.
Great, thank you. And
Yeah.
Kanapatipili, greetings, how are you? Please tell us.
How are you
how
doing,
you are.
Amanda and Musa? Thank you for letting me to speak. My name is Sri Ranjan. I'm the president-elect for WONCA 2023-25. And I'm really working on a postgraduate qualification acceptable to our region, which is a very divided region, something similar to Mediterranean, where they have an MSc in family medicine, which is accepted by the region. So we are working on I'm working on that program, which is, we already have an MRCGP int for the region. So I'm thinking whether we can develop it into a further and a postgraduate specialist qualification in the region. For this matter, I have spoken to a couple of people in India, Pakistan, and Bangladesh. There are a lot of positive signs, but there are negative signs too. So this is where I'm working on, Amanda.
Okay, well, very good wishes with that. And hopefully some of the lessons from colleagues today you can be using to help you there. And
course.
Shabir, finally, and then please go into your presentation.
Well, thank you all. My name is Shabir Musa. I'm a family physician in Johannesburg, and we'll share more about my history in the presentation. I think just to introduce Mercy Wanjala, she's just joined us. She'll present just now, but perhaps she can do a quick presentation. I think Ugoji hasn't presented themselves. Perhaps Amanda, you can let her do that. And I think Sanka's just joining us as well. So you muted
On my
Amanda?
participant
Yes.
list, so I couldn't see that there were other people.
All right. Do you want to call on, perhaps Mercy can, Sanka and then Ugoji? Sanka, perhaps you could just introduce yourself before I start, and Ugoji, and then Mercy, and then I'll start.
Hi. Actually, I'm on the way, but anyway, I'm Sanka. I'm a family physician from Sri Lanka, and also I'm the Young Doctors Lead of the WONCA. Thank you. I'm also I'm actively involved in the SIG-GON policy.
Wow. Good, thank you. Ugoji?
I'm Dr. Ugoji.
Yes.
I'm Dr. Ugoji. I practice family medicine in Warri, Nigeria.
Right. Welcome. Great to have you. Mercy, perhaps quickly. Yes.
Hello, everyone. Mercy Wanjala. I'm a family physician from Kenya and the Executive Coordinator for Africa Forum for Primary Healthcare. I also take an active role in a number of WONCA working parties and SIGs as well. It's a pleasure to be here today. Thank you.
Thank you. Well, let me start. Essentially, the theme is just sharing lessons from advocacy in Africa on family medicine. And I will just share my journey, which has been, I'll share a bit more detail, but basically it's 4 segments. The experience in about 17 years ago when I came to Gauteng, a very small province, very big in population, very big in economy. From a very rural community. And then what I did in terms of setting up practice as a way to model things, the implication it had for the South African National Health Insurance efforts, and then some of what we did trying to spread this kind of approach to the rest of Africa, which we'll share with you. So, there's a map of South Africa on the right-hand side, and I born in Durban and trained in the University of KwaZulu-Natal. You'll see it on the border on the coast in KZN. After working there, after studying there, I then went to a small country town called Kokstad, which is on the border of KwaZulu-Natal and Eastern Cape. You cannot see it there, but it's just on the line, literally, of the border. Then at that time, I was a GP leader, private GP. I actually worked in a very rural community, literally going on bumpy roads, serving in little huts and stuff like that. I was also the leader of the private doctors in that area, called an Independent Practitioner Association. So I've had that kind of background in experience. When I moved, I was trained as a family physician, but it was more based on vocational training inside with a distance-based master's training in South Africa, and I completed in about that time, in 2001. So when I moved to Gauteng, which you can see in the map, is really a very small province, but it has the largest population, 16 million out of the 66 in South Africa. And Johannesburg, if you look at that Gauteng map, is actually the smallest geographic of Gauteng as a city, one of the cities of Gauteng, but it is the largest city in South Africa with 6 million. And the economic powerhouse, literally. When I came to Johannesburg, it was to help Bruce Sparks, previous WONCA president, develop a training platform in 2004 for family medicine training, as we're moving away from this very part-time vocational training towards a full-time registrarship in family medicine. And that emerged around 2008. But when I, came along and then engaged with a manager who was quite senior in the province and in Johannesburg to say, let's work on a plan, he, after setting up some plan, called the head of department and said, who happened to be a nurse, public health specialist, who was in the School of Public Health and worked on the same floor in the medical school as Bruce had done. Her initial response was, does he come from Bruce's department, which I was? And she said, I'm not interested. Her notion of what family medicine was about, well, that's all about private GPs. And in the public service of South Africa at that time, we cannot put GPs into the system. We can't have GP-led care. We need nurse-led care. Of course, they wanted doctors. So she turned around and said, listen, go and tell him to talk to other managers and let's see. And I thought that was really fortunate, because what I did is I said to the manager, who was quite distraught, I said, well, let's use that. I then spoke to every manager in, senior around her, and he facilitated the connection. And I went to them, and one of the approaches I used was to say, what are your thoughts about family medicine? And then clarified the thinking around it. And then asked them, what do you see as what we should be doing? And in that kind of iterative way, built up ideas. She then, in February, called herself called the manager and said, I want this doctor to present, Bruce's department or the guy you talked about to present. And so we went to a workshop of senior managers in February of 2005, literally 6 months later. And she said, I like it. And then we worked on a workshop in July to get the senior managers together. And by the end of the year, it was signed into existence that we would have joint appointed, university appointed family physicians who are going to head the doctors in each of these districts, which are the metros, partly metropolitan, these various districts you see in front of you, and lead doctors with family physician set. I mean, at that time in that engagement, a lot of the challenge was when I was, her notion of doctors, family physicians are all about personal care and don't seem relevant to the public service in poorly resourced circumstances was a challenge. And it took quite a while to share with them, listen, in South Africa, yes, that's the way it's been for quite a while. It's had its beginnings in private practice. But in fact, in South Africa, with Sam Ferson and other people in Medunsa, there was a very strong rural flavor to family medicine in South Africa coming along, which suggested that family physicians actually have a real place in the public service of South Africa. And just give me a second. I just need to give sharing rights to Mercy so that she can just allow people in. Mercy, if you don't mind just admitting people. So some of the key things that I had to negotiate was that we initially said that it needs to be, they were talking about, we can't have doctors only. No, sure, it's a doctor and a nurse, and we work with that, but the doctor has an important role in terms of building quality and building faith in the system, which in 1994 was set up from nothing to universal coverage based on nurses being very available to literally any person in South Africa within five kilometers. The difficulty with that was that the quality wasn't as much as people expected. And so they were kind of hankering after doctors, which were not available, and then going to hospitals, which the managers didn't like. So they wanted us to attract more doctors into the service, but they had these hang-ups. And one was, listen, is it based on teamwork? We said, no, it's about teamwork, and that's the role of the doctor. The second thing we talked about quite extensively was that it needs to be very community-centered and population-centered, that we're looking after communities. We need to move away from biomedical and responsive healthcare, medical care, towards, sorry, I'm not sure who's, let me just mute some people. So it is about preventive care, and we need to stress that. The third thing we emphasized was that we needed to focus on the priorities. So we heard a lot about what is the role with regards to HIV, although at that time it was a little dicey, but mother and child, etc. So we responded by saying, yes, this is very important. And we looked at their priority and our priorities and tried to find middle ground. Our priority obviously being that we need quality, etc. And then I think it was about, I think those were the big issues that we had to try and build consensus about. So as I say, it set it up, they accepted it. And then I was acting as the HOD of family medicine, the family physician in the district of Johannesburg, where after a few years, I found that even though we were doing this, put this plan forward, there was strong resistance. People said, we don't understand. And the problem was that they actually struggled with the concept of family medicine, but there was also a power struggle within the district where nurses felt, no, listen, this person is coming in and taking over our authority, which we have established, since '94. So clearly there were the politics as well as the clarity of thinking about a concept like family medicine. So it was a lot of work done. And after 2011, I actually abdicated the role of family physician. And in that time, I'd spent time, even at a very provincial level, trying to coordinate family medicine and realize that, there needs to be more change and the system needs changing to, allow the role of family medicine to flourish better. I think the lessons that come from this, it was really sitting and being very clear about who are the stakeholders and asking people repetitively, who is the one that matters? And slowly with the senior people really understand clearly who's important and who's influential. And I think that there are stakeholder analyses templates which can be useful. People who hold power versus people who hold influence or are important in the process. And one can actually find ways to look for those with a lot of power and influence or importance and try and build alliances in that way. And I think that really is something you've got to focus on, who's most important in this process on a very regular basis. Understanding priorities as well as merging these priorities. In other words, looking at their priorities, our priorities, but finding middle path and looking for win-wins and looking for things that allow us to progress and not seeing differences, looking for the common. I think it is about, importantly, that we understand other people. So listening is important, but understanding that, that we have to understand the terrain of nurses feeling threatened by family medicine and finding ways in which we could build that space where we're not competitive and seen as collaborative. I mean, at one point, Bruce turned around when this was signed off turned around and said, well, it's the same thing I was talking about. Maybe the language is different. But the truth is that is really the key problem. We need to think carefully about the language, and it comes from us listening better to other people and understanding what they think is important, and then trying to engage with them with that process. And we had some very interesting discussions this morning about how one can do homework before, to make sure you're really getting through to that before you are called on to make presentations. So others I'll share similarly, and I think there are elements that still happen in all of them, but I think those were the sort of useful experiences. Well, after, about 2008, our government said, what we've tried to do, bringing in doctors, is not winning. And this was across the country. We had actually succeeded in Johannesburg, doubling the number of doctors, but it was never enough. Going from, 80 to 160, is not going to change things for 6 million people. So clearly there's a strong problem in the community. They say, where are the doctors in the middle of this process? And we want them to be part of it. So it led to this National Health Insurance Plan, where the government decided on including private providers, because we had lost a lot of doctors to the private sector. And they said, let's work with strategic purchasing, with capitation payment for primary health care. And that was the model that they were punting even from that point. So when I had moved out, I completed my MBA, and a study I did was on GPs exploring the question of primary health care capitation. And I asked the question about the cost effective, or the cost that they would, in other words, what they would charge, effectively the cost to government. And it landed up being very, very similar to the current cost at the time of the public service, which was quite strange for many people. But I asked them about what do they see as risks, and how would they mitigate these risks? And they came up with three things, essentially, three themes. One was that the government is a very unreliable partner. And if they have to mitigate that, they would want very strong contracting with strong frameworks or strong contracts. The second problem they brought up is in the scenario that was painted, looking after 10,000 people with a utilization of 3 visits per person per year. They said the scenario that they had with 120 people would see a lot more people coming, because the 3 visits per person per year was very low, and they expected more people. The third thing they came up, and of course, the mitigation was mostly we would do health promotion. Some of them said they would ration care. The third thing they came up with was that we need to we're moving from 25 people a day as our small solo practice. And now you're talking about 120 people a day. That's a huge shift in our practice paradigm. And that's a huge risk. And the way we'd mitigate it is by being better managers, which we're not trained for. So clearly they had picked up some very important issues in the notion of capitation. Of course, it was a very clumsy, straight capitation scenario that was painted to make the study easier. So I said, let me set up a practice in the public service to see, because it's not easy to do in private. And, I was in the public service. So I said, let me try to effect such a model of 10,000 people that are in a panel, that are cared for by a family physician in a team, and what would we achieve, especially in terms of family medicine practice, but particularly in terms of the utilization of a defined population, because it matters. It was a very big conversation item at the time that the costs of NHI are very high, yet we had shown that the costs were not necessarily high. And so I said, let's see what we can do, and whether we could be proactively using some of the principles of community-oriented primary care to do health promotion and actually reduce the visits, but actually improve the quality of care. And we shared this regularly, what we were doing and what we were achieving over the time, regularly in emails. So in that process, we found ourselves, the lessons were that really you need to build on evidence and you need to model. And as family physicians, that to me is very important, because you can talk what you want, but people are slowly, and it is still a problem in the implementation of family medicine in Gauteng, where people are saying, but we don't see the difference you're making. Of course, in Shawelo, we were able to show 4 differences in terms of the quality of care. We were able to show the utilization being low, that the satisfaction rates and access were very high. And this was some of the evidence that came out of it. and we were regularly sharing. So communicating to me is very important, that you find ways to share what you have achieved and couch it in terms of evidence. I think the third thing was, after from 2011 to 2015, there were a number of papers. And then in 2017, the National Treasury, I happened to get an email of someone in Treasury, and I was, it was one of my literally 10,000 contacts that I accumulated, and I was just sending monthly shares. And as I did that, this person would 1 or 2 times respond to me, but then he reached out to me in 2018 and said, can you come to a meeting where we'd like you to share? He liked the project in Shawelo, and he said, can you share that where we're thinking about the capitation issues that we're trying to implement in the country? And I did do it. And then he said, please bid for the design of a GP capitation contract, which I took about a year or so to do, together with an actuary that they had employed. And essentially what I did was, again, listening to both the public and private sector, which I'd been doing, and engaged further with, we found a model that actually fitted both terrains, which is the concept in the whole NHI. And we put together this based on a primary healthcare clinic, which is pretty much the most universal kind of structure of care in South Africa. And then we said, let's add a doctor per 10,000 of such a clinic, and then find ways in which we get them to do what we need to do as a team. And the principles were effectively to say, get primary healthcare teamwork, very similar to the conversation we've had before, and let's prioritize important diseases that the government wants to do. We stress the question of community-oriented primary care, using the ideas in Shawelo. But again, in terms of engaging, people like from the UK as consultants came along, and they didn't understand how to implement it. And we said, there's a way. And, eventually that won the day. We also stressed the importance of referral, because that's a problem in capitation payment systems, that in fact referral or lack of care is one of the considerations. We, in fact, in that process said, every doctor needs to be part of a review process, and we need to engage them in training around family medicine, and that should be a diploma that is part of the process. It makes sense, especially when you put it as part of the package that a department wants to try and, a government wants to implement. And then we said, really, data needs to be collected. At the moment, it's very much paper-based, very top-heavy. And we said, listen, let's move to electronic, collect less, make it part of the process, but in fact, make it very, very strong in terms of outcomes. And that was the thing that happened. Now, that process was actually undertaken with National Department of Health, but it seems there were tensions between the Treasury and Department of Health, and that process was not taken up. However, over 5 years, very frustrating sharing it in all sorts of places. But eventually it did find a room where, when the National Department of Health finally started doing things as the district family physician role, which I occupied again from last year, I found the opportunity to share that with the chief director of the district, and she loved it and said, well, that seems to be our position for Joburg, and let's talk to Gauteng, and eventually was taken up by the province. And now I am the lead manager for the implementation of the National Health Insurance in Johannesburg in terms of the PHC. So in a way, it comes full circle, but the lessons persist. You have the same issues, try to understand where people are at using the team, the community-oriented primary care. These are very laudable ideas, and you find that you can talk to the same issues and find ways that people say, this is what I want, and you make it theirs in that process. And again, modeling and evidence became very key to this process. We, in fact, are trying to show the evidence of the model itself, that it can work in the proof of concept that we're doing in Soweto, in Johannesburg now. Again, communicating, produce the results, and persistence, because we said, there's no other way. They have to take this up, and it found room. And in terms of, its impact nationally, I just shared some of the work in a national meeting, and the national and provinces love the ideas. So clearly it's going that way. We just have to find ways to speak the language. The last one, I'm going to be very brief. I want to finish in the next 5 minutes, is basically an Afro-PHC experience where he said, and I was basically WONCA chair from 2019, but I've been involved since 2014, 2012. And I've been long saying, you know, we need to actually take this forward. And so when I had the opportunity as president, we had in our workshop, where we managed to get the WHO and have a workshop in our conference, we talked about what can we do to sort of advance family medicine across Africa. And one of the things that came up, and we shared some of the experience in South Africa, Jan de Masters suggested, why not create a forum across Africa like the European Forum for Primary Care? And so we birthed the idea of an African Forum for Primary Health Care. We took it to the African Interprofessional Educational Network, which is very educational, but we found a huge array of people, and we took it to one or two other forums and organizations, build a common set of values, got people to subscribe to it, and then we said, let's just get going. And in a way, we didn't go quickly to set up organizations. We said, let's build togetherness, common shared values. We set up a process of policy workshops to say, let's talk to each other better, let's understand each other. And we took topics, and in that process, we started realizing that we actually share more than we differ with. And it, in a way, became a very important space to create thoughts and around several issues. And that was some of the conversation with WHO in a workshop. And then we finally launched in 2021, you know, after a year of being very interim. And in that process, we got an executive board, which was very individual. We said, we have this organizational support. Let's keep them on board by getting to support it, by becoming part of an advisory board so that they still have voice. And then as we went forward, I basically became the executive coordinator for the board and realized that the board was not necessarily active individuals. So we basically looked, with the board's permission, to recruit young people and said, come along, I will mentor you. And in that process, we want you to do things and get engaged and start doing things. And we had a really strong strategy around attracting young people, especially people who had been previously leaders in African bodies, to say, come along, you've got a space here. You know, that you're there for a year, but come along to join us. And we've been strategizing around how to do that. And it's really been successful that in a year, literally, we were lucky, we got a micro grant in part to the energy of that executive coordination team. It's culminated in a workshop that Mercy will share just now. And I felt comfortable enough with Mercy being mentored to become the next executive coordinator to say, it's time for me to leave. Let Mercy, who literally came in January, to continue as the next executive coordinator with another young person as a deputy. And I think that the board and the advisory board is a huge mix that Mercy could share a little bit about, of people and interest in primary health care that stretch from community health worker to patient to economist to family physician, nurses, and everything in between. So it's really a very robust forum. I think the lessons, again, very similar lessons. We use very much the same thing, but I think it also share this idea that when you build organizations, be prepared to work with it and evolve it and not try to control too much. And rather, as family physicians, to be more influential than try to control it. And I think this is really important in the way we've gone on. For example, the Afro-PHC met the WHO Afro last week. And in that, we said it can't be 3 family physicians representing this organization, even though they feature at the top. But let's make sure nurses are part of it, and we rearrange the delegation to suit. And I think that's exactly the kind of thing we need to build up our credibility. And it's been amazingly successful in Africa to go about this process. And I think that is my message to all of you, to say, do embrace, because I think the African setting is a very challenging one for family physicians. And I think there are plenty of lessons. I'm sure others have such useful lessons as well. I think we have a wide array of people from very different places. So it's really great that we can share that. So thank you, Amanda, and thank you all for listening. We can have a little bit of a chat. I hope I'm not taking too much time. Amanda, are you managing?
Yes, you just had to allow to unmute me. Thank you.
No problem.
It's a good idea, though. So thank you very much, Shabir. Welcome to colleagues who joined after the start. We have a few more guests, Pilar, Larry, Pashkevi, and Scott. Lovely to have you here. Welcome. And if you have any question or comment for Shabir about Shabir's work before we let Mercy give us the second chapter, then please put your hands up. Shabir, can you just stop sharing the screen so we can see colleagues?
Yeah, let me just allow people to unmute themselves. I think we had that switched off. So any of you could now unmute yourself if you want to speak.
And now I can see everybody as well, I think.
Yeah.
So any questions, comments, colleagues? I mean, the thing that struck me particularly hearing it the second time was this long piece of work and the evolving vision, I'm sure, from where you started, Shabir, sort of going from an individual locality into the idea of a different model of a system, and then a whole system approach with many partners. And knowing that you yourself are quite you really have a passion for these things, I'm also struck by the patience and endeavor that you must have had to put into this. So I think they say, don't they, colleagues, in resilience, one of them is to be a little bit pragmatic, but to persist. So anyway, those were two things that struck me. Larry, I think you put your hand up, and then Pilar. So Larry first.
Sorry to be late, Shabir, but the part I got from that is very exciting. My question for you is about what well, let me base it on Soweto and Johannesburg, but then also your views about across Africa. Is there a public view of primary health care? Does the public have a sense of what this is? And do they have, within that, is there a sanctioned role for a family doctor? An expectation of what a family doctor is and does in healthcare? Does that exist across the population of Soweto? Is that understood well throughout Johannesburg and then on across the continent?
Yep, I think, do you want me to respond immediately, Amanda? You unmuted.
Yes, if you would just respond briefly, because
yes, I'll keep it brief.
And then we can build it with Mercy.
Others, yes. So thanks, Larry. I think the question of how people feel about doctors, they're kind of resigned to the fact that they can only access what they can access. In an African setting, I think that's the way it works, even in Soweto. What does happen in South Africa is that what doesn't happen as easily, I think, in African countries is that the private sector, Mercy can share, that if I'm wrong, I think there is in urban centers a very vibrant private sector, and in South Africa, pretty much a vibrant private sector across the country. So people know if they go to a doctor, they will get better care. They just see a doctor. They don't know about family doctor, a family physician. They just say a generalist coming and dealing with things. That's their notion of a family physician. Now, I mean, the idea of quality, of course, is something people like. When you ask them, what do you mean by quality? Very often it's about the doctor speaks well to me. He examines me. He deals with my problems, which are all elements of quality. And it's something that people have to be reminded. It's not very easy to say, well, I spent 4 years more to train to be talking better, and that doesn't get across. So your skills are not very visible. Whereas not even visible to the manager, because if you tell him that, he'll just laugh at you and say, well, I'm paying you literally more than the medical officer, but we've got really great medical officers. And you know that we've got great graduates from South Africa that go elsewhere. They just may not be as courteous, etc. But clinically, they work pretty well. The challenge in South Africa and in Africa is to say, listen, there are competencies in hospitals, and that's been a big selling point to managers because they see the value. Oh, okay, you can be a substitute for a specialist. So they like that idea. And then you come with the notion, but we're very community oriented, and they're like, I don't know how you're going to do that, but that's great too. And you kind of seem a fix. But when you are taken into the system, the first thing they say is the hospital needs you. And they kind of bounce around. When you're in the terrain of the clinic, you struggle. So even the community orientation struggles to happen because you are in the middle of a very nurse-dominated biomedical system. So I think the question you ask of public perceptions, I think it is not a strongly clear, a population that doesn't know the differences very well. And I'm not sure, it'll take time for them to sift that difference out. Thanks, Amanda.
What I noticed, Larry, when I was there and in a couple of other places as well, was that people who'd experienced a clinic without a family doctor there, and then when family doctors started to be in the clinic, they would say, oh, it's much better now because he does this or she does that, and we didn't have to go to hospital and we didn't have to pay extra. So I think the patient, the community themselves often notice the change and start to then advocate for it. But when they're not in that situation, it's more complex. But,
perhaps I can just quickly respond, if I may just quickly respond to that.
Okay.
The exact, what Amanda said is exactly what we experienced in Shawelo. So the people if I go to, let's say, the normal queue, patients will complain about time, etc. But only when they came to come to the Shawelo community practice, then they said, this is so much better. That is terrible. And then they sort of have a comparison, whereas now they don't sense a comparison easily, except if they go to a private doctor. And that's their notion of, yeah, that is much better. So, yep, it's true. I think, Amanda, that's a very good point.
Thanks. Pilar?
Thank you. First of all, congratulations to be, because I think to build up a model, and that's crucial to have models to follow and be implemented in the in your own context. I think, as Amanda said before, the patient endeavor and resilience is crucial, because the primary healthcare, the outcomes are long term, so sometimes it's difficult to have outcomes quite close. So I'm just thinking, you have been talking about training, focus on the community as well. If we do a trainee of family doctors quite related to hospitals, and then they could become like hospitalists in primary healthcare, and we have not to lose the role in the community. So within this model, have you tried to define the role of family doctors with the team, with the leaderships, to make the team reasoning together, everyone from their perspective, that are complementary, but not making the message of substitution?
Yeah, very briefly, I think that's been the task all the time in all the engagements around advocating, is that we are not here to substitute, we're here to work as a team and to achieve results together. Unfortunately, when you come into a space that doesn't have you as a phenomenon, it's very immediately a threat to people who were if you walk into, as a family physician, I'm not sure whether you have that situation where nurses are only operative and they do everything. When you come in, at a very local level, they might see that as a benefit. But in management, and this is the nature of this beast in Africa, in South Africa, is that nurses dominate the various levels of managers. And you come along to say, are you actually going to become our boss now? And in South Africa, there was a precedent where Black nurses had to answer to a white doctor, and that was a Black female nurse to a white male doctor. So you can imagine the sense of empowerment post-apartheid, and now a sense of, is this disempowering us, and the clash that exists. So it's not an easy environment to walk into. So it has been a challenge. And I think in a way we have consistently said, we are not managers, you are the manager, you're responsible, but we are here to support you, and we want to actually focus on clinical governance. Unfortunately, the clinical issue has been very late in being recognized as a distinct element that needs leadership by family physicians. So even though I started in South Africa, I mean, in Gauteng in 2004, it was only in 2018 that in the districts, the MEC said, we want clinical governance. So it's really the long experience with nurses just not managing the clinical challenges has led to people saying doctors need to take over. But it's a function of the politics of the situation, and you sometimes have to just bide your time and find ways in which you can influence it. I mean, just an example of working with communities and I think modeling it at a very local level. You know, when I started in Shawelo, literally I had funds to last me about 2 years. I employed community health workers, we set it up. By the 2 years, literally the funds ran out. But because we had engaged community health workers to go into the community, register people and be the link, and they were really strong in this program, be part of the team, then we had a clinical associate, myself, and 1 or 2 nurses. And then we got into the community. At the practice itself, we just said, let's practice good family medicine, good records, teamwork, etc. And then we got to the community, and we got a lot of community leaders. And, we asked, who else is important? Who else is important? Let's bring them in, engage them, either outside in groups or otherwise. And then try to take the information from all to do targeted health promotion. We were literally at the end of our tether, and the managers were determined to not allow the community health workers we employed to be absorbed into the health system. And they were unpaid for 3 months. And I was away at a WONCA conference when I got a call by the MEC. It turns out the MEC is basically the minister in the province, the minister of health in the province. She had done a little tour of the facility. As she was going out, one of the community members said, but MEC, you have not seen Shawelo community practice. Can we go back there? Took her back there and was right at the corner of the whole CHC. And she said, look at this. And the community health workers who are literally running the place shared with her what this model is about. And, one critic turned around and said, the only thing Dr. Musa did differently from me during COPC was he empowered the community health workers. Well, to me, that was the best accolade he could give me, because they did it. They actually succeeded in convincing that MEC that the model works. And she essentially said, I want it rolled across the whole of the Gauteng, and literally put the program back on track. So I want to share with you the importance of community organizations and the engagement with communities and modeling to care around communities. And COPC does exactly that. So you can easily become an insurrectionist as a community-oriented primary care family doctor.
Why change the habit of a lifetime? But seriously, so another lesson that we've talked about in advocacy is whose voice will help us most. It often isn't the doctor or the nurse, it's the community, it's the patient. And also, of course, a great respect that, to them for having seen what is of value. So lots to discuss, but this point about when you are trying to speak up for something, because they will always say, oh, well, you're a family doctor, you would say that, wouldn't you? But if community is saying it, or a nurse colleague is saying, no, this worked in our place and it saved money and the care was better, etc. So great. Now I'm going to invite Mercy to take the stage now and to give the second presentation, because it adds another dimension, I think, to what Shabir has already presented about another way of working in partnership. So Mercy, please be welcome and share with us your learning.
Okay, thank you, Amanda. Good evening. I don't know, good afternoon or good morning to anyone who's still in those time zones. So I'm going to share briefly about my experience of advocacy in family medicine, and then just dive into a bit of how policy briefs can be used as a very good tool to advance advocacy in family medicine. Just a little bit about my history and family medicine. So I'm a young family physician, young in the family medicine discipline. I did my residency in Cuba and then came back to practice in Kenya. It was part of a government program to try and advance the agenda of PHC that had begun in the country, which was PHC for UHC. So that is me, and it was during the COVID period. You can see we were just using simple cloth masks. That was me at my desk, just filling in my worksheet for the day, and also just working on a few patients' notes and other things after going out to the community and doing home visits for the elderly, because during COVID, that was my job. I'd go and visit the old elderly who are living by themselves. And so you see at the middle, I put this is a manual that you are using. You can see family doctor and nurse program. So you can see in Cuba, there was actually no need to do any advocacy around family medicine. Family medicine is the foundation of everything they do in healthcare, all the way from the time they signed on to the alma mater till now. Family medicine is all they know. Family doctors is all they know in the community. So that was a bit different. So to the left, far left side, that is the Cuban family physician whom I was working with. So our desks were across from each other. So depending on the clinical consultation day, we could either sit in the same room, or the nurse would sit across from him, or the nurse would use the other room, depending on what we were doing that day. So contrasting with what I came back home in Kenya, nobody knows much about, not nobody, I'd say majority of the community, even the healthcare professionals, don't understand what family medicine is. So when I went back to Kenya and I went back to my county, which is called Embu County, I had to go back with a presentation just to ensure that everybody knows what family medicine is. Because I had learned from those who are doing family medicine advocacy already, those who had come before us, because we just had a conference, our very first conference as family physicians. And we talked about the issue of family medicine and the place of family medicine, because everyone keeps asking, who are these family physicians? So when I went back, the first question I was asked is, are you an internal medicine doctor or physician? So I had to explain, no, that is a different kind of physician. A family physician or a family doctor is a doctor who is trained to work with the community, in the community, and I explained the role of a family physician in the community, because that is a concept that was called for and even in Kenya, because even the family medicine trained physicians in Kenya, we have what we call hospitalists. Most of them are hospitalists. Very few, if any of them, work with the community, in the community. And yet my training in Cuba was just to work in the community, with the community. Our hospital rotations were only to just learn a few clinical skills, etc., but our work was mainly in the community. So I had to explain that dimension to our county director of health so that he can post me in the right place, which is in the community, to create a network and what we are calling a multidisciplinary team in order to strengthen the primary healthcare system. And I'd say we're also facing here the same problems that Shabir faced in South Africa. The issue of the primary healthcare space was occupied by other people before family doctors started walking into that space, I might say, because we have public health officers, nurses, and in a few cases where we have what we call health centers, which are what we call our level 3 of healthcare here in Kenya, you might find some clinical officers or what you can refer to as clinical associates. So that's the same issue. The primary healthcare space was previously majorly occupied by nurses, public health officers who do preventive and promotive health in the community, and what we call health promotion officers. So when they find this family doctor who comes and wants to support the same thing, but also with another clinical dimension and clinical leadership and governance, then it becomes a tussle. Why are you walking into our space? We have been doing this all these years.
what is it that is new that you're bringing to us? So those are some of the questions that we're getting and wondering what to do about it. So I was successful in that I found myself in the place where I ought to be as a family physician, as compared to some of my colleagues who either were posted to an ICU, internal medicine ward, the surgical ward or the surgery department, basically any department that had lacked a specialist or a consultant. That's where some of them were posted. So I did not want the same. So I decided to speak up for myself before getting there. So that's a bit about my story. And you can see here it's a headache because still we're grappling with the question of what is family medicine? What is a family doctor in the Kenyan context, for instance, and what do they do? And I think that also reflects in the African context as well. Prof. Shabir has talked a little bit about Afro-PHC and where Afro-PHC came from. And I'm just going to talk a bit about Afro-PHC and the strategic objectives that we have had and we are continuing to build on even in this coming year. So one very important one and the most important is engaging and advocating with stakeholders on appropriate PHC human resources and strong PHC teamwork. Strengthening social accountable PHC for communities in Africa, supporting local and country level PHC for teamwork across Africa. And one of the major ways we are doing that is through the policy framework, which we have been developing and are actually just preparing to now launch the document on building PHC teams for UHC in Africa. Also capacitating PHC stakeholders at policy, management, clinical, and health level through our various programs, like we have the ARM, which is the Afro-PHC Research Mentorship, where we're trying to generate evidence. We also have the leadership and management course that we partner with AMREF with. We have our policy workshops from which a lot of the content of the policy framework was drawn from. That is the voices of the frontline primary healthcare workers in Africa. We are also working on, I've mentioned the building research evidence for appropriate human resources and strong PHC teamwork, sharing information, communicating effectively. So we do that through we have a mailing list where we have, right now we've reached, I think, about 1,600 people on that list, and they're also allowed to, it's a Google group actually. So everyone communicates on that Google group. If you need maybe a research paper that you cannot find, or you need to be connected with anyone within the region, you're free to ask in that group, because we have quite a wide array of people in that group, from policymakers all the way to community health volunteers and community health workers, health economists, people who work in other areas in government. So it's quite a wide group of people, but all of them have one thing in common. They want to strengthen PHC in the region, and also building membership as an organization, because we want to build consensus around primary healthcare in Africa and what it can look like in the African region. So this is a bit of an overview and background on the policy framework I've talked about. So the background focuses on heeding the call of African health professionals, where we talk about a lot of the sentiments that were brought out in one, the policy workshops that we have been holding, and two, the stakeholder engagements that we held throughout the process, where we have developed about 7 chapters. Right now, we are aiming for 10 across the region, and we use those chapters and other fora like our advisory board that Prof. Shabir mentioned to just get a feel of what are the challenges of different healthcare professionals in Africa, especially the ones on the front line. What are the things that they think that their governments can do or they themselves can do as solutions to strengthen PHC as well? And so the other thing about the background is recognizing what are the challenges that we have in Africa as a region, and what are some of the opportunities that we can leverage as a region in order to advance PHC, and also noting the PHC global milestones that we have had so far, and how we can leverage these milestones to really improve PHC in the region. And the key elements of this call are, one, of course, HRH, training, recruiting, and maintaining a sufficient frontline PHC workforce, because we noticed throughout all our consultations and our policy workshops, when we go to the breakout groups and have discussions, one of the things that would come up is there's not enough human resource. The human resource does not have enough capacity to deliver, and also there's no enough financial resource, bringing me to the second point, which is support PHC with resources. We need resources in order for primary healthcare to grow in the region, and also build resilient and robust primary healthcare system. Because if there's one thing that we've learned from COVID is that if you have a strong PHC system, you literally have a system that can bounce back from any kind of disruption caused by a pandemic or any other kind of disaster. And the best response is actually the kind of response you can mount through your primary healthcare system. So that's a bit about the document. You can go to our website. There's a draft of the document, but we're planning to release one once we we launch. We'll release one to the public, and everyone will be able to get access, and you can read more about it. So this was us visiting the practice that Prof. Shabir talked about. So this team was a multidisciplinary team from different parts of the world, different parts of Africa, different professions. We all came together to discuss the policy framework and have the input of everybody and every organization and every cadre that was represented. And we had a walk through Chiawelo community practice, and it was actually good to walk through the ideas that Prof. Shabir has brought forth to see what he set up and what it has managed to accomplish, because this is a good example of evidence of how bringing down family practice to the community level can really transform the community primary healthcare centers. On the other side, you have the Afro PHC executive coordinating team and members of the board who had met also to just discuss the strategic plan amongst other things and plan going forward. And also Prof. Shabir, who's been mentoring me in family medicine advocacy and also advocacy in PHC, amongst other things, was handing over. So just going now down to the issue of the discipline of family medicine, and especially sub-Saharan Africa. As you can see from the examples and also from our experiences, it's still struggling to find its place. And the thing is, we need stronger and better evidence on the impact of family medicine on the health of population. And one of the most critical things, as it has been talked about earlier, is the issue of the community recognizing that importance and actually asking for it. Because if I can give an example from what I have realized on the ground, I have not yet to do formal research on this, but just while I was visiting the various primary healthcare centers in my county and getting familiar with all the primary healthcare centers that we have, one of the things that I realized is the community, when you talk to the community health workers, the community health volunteers, and also some members of the community, because I also got a chance to do that, one of the things that they said is, when we asked them what challenges do you have, they said we need more nurses. But I understood why they said we need more nurses, because all they've ever known is nurses, especially in those rural and rough terrains. Because we have places where even a vehicle, we actually got a puncture just trying to access some of the facilities. And for people who live in such far-flung rural areas, the only thing they've known at the primary healthcare level as first contact is nurses. So that made me understand why every time the county was employing, it was employing nurses, because nurses are the boots on the ground, literally. And that is what the community knows. So when they're asking their leaders for what they need, they say we need more, and they specify nurses. So there's need for stronger evidence, even at the community level in terms of family practice, and also improved government support, because without government support, policy doesn't change. Resources don't fly down to support the practice and also to bring down family medicine and family practice to the community. So this makes the use of policy briefs a very important thing. But if we look at the use of policy briefs across the region as an advocacy tool, it is not as widely used. You'll find other organizations, for example, like WHO and other international organizations, use policy briefs a lot when it comes to advocating with member states, but not, for example, organizations for family medicine, etc., within the region. So there's a need to use policy briefs as a tool. Policy brief is simply a summary of your issue. It is literally just an advocacy document. To me, that's usually what I usually tell myself is, when I'm writing a policy brief, I'm actually writing an advocacy document. And because at the end of the day, the main reason why you're writing a policy brief is to advocate for an issue. So the two actually are quite intertwined, and they go hand in hand. And some of the best practices are what I'd call the miniskirt rule. Just do a one-pager. Don't do too many pages, because most of the time, the policymakers that we want to hear our issue, some of the people we want to build consensus with and bring them over, there's so much to do. There's so many documents that they're writing. There's so many people who are petitioning them. So it's good to just I call it a one-pager, because that is what we call it at work. Whenever you want to to present an issue to the governor, you write what is called the one-pager, which is literally a policy brief. And then a simple structure just with a title, a short executive summary, and of the problem. What is your problem? So that it is very clear what your issue is and what you're advocating for. And then from there, it is good to build up a bit of evidence. What research do you have, either current and past proposed policies that have worked or will work or should work? And from there, you just give recommendations once you've given your issue. For example, if my issue today is the fact that there are not enough family physicians trained in the country. So I would want to say my problem is training of family physicians. We have too few family physicians because we are not training enough. So that is basically my issue. So I'd want to go and look at what is the problem. So for example, I'd want to go and build statistics around how many have been trained, how many are needed, versus vis-a-vis the population that we have, and bring in the issue of strengthening primary healthcare as well. And then the other important thing is, as I'm writing all this, I need to think about my audience, because your words and your wording will depend on your audience. So if you're writing to policymakers who maybe are seasoned family physicians themselves, or in one way or the other are healthcare providers or understand the healthcare system and healthcare jargon, then you might use some technical terms. But if you're writing, for example, to a politician, or even a minister but does not have a healthcare background, then you want to use words that are easy to read and easy to understand. So here, I said avoid mansplaining, because you need to understand the background of the person you're giving this information. For example, if your governor, senator, whoever it is you're writing to has had this story before, you don't want to rewrite or say again the things that they've heard, the things that have been written. Either you pull things from the media and try to write them within your policy brief again, so that it doesn't sound like you're over-explaining something that they already understand. So reading the room and understanding who your audience is very key, even as you're developing your brief. And moving on to the issue of keeping it short, it is important that you prioritize your issue. What is your urgent issue? How urgent is it? And why should this person care? And why should they respond now? Because if you write it in such a way that, first of all, you have not prioritized your issue, that your issue is important and urgent, then this person will wonder, why are you making me read this one-pager at 6 a.m. in the morning when my PA is briefing me on these issues? So that needs to come out very clearly, the fact that this is an issue that requires to be prioritized. It is important, it is urgent, and if it is not addressed, for instance, these are the possible consequences. And as you're saying that, don't back up that with emotion, because if you appeal to the emotion, then you're not appealing to what matters to them. Because you need to understand, for instance, this policymaker who has come into place or who has been there, what are their interests? What is it that they want at the end of the day, so that you create a win-win situation and make them understand why, amongst all the issues that they have to deal with today or tomorrow or this week or this month, why is your issue an issue they have to address now? Then, in order to make sure that you back up your claim well, and also in terms of ensuring that you're speaking from a point of solid facts and not just appealing to someone's emotion, because remember, when you write, that's a thing that is different from when you're talking. When I'm talking, I can afford to appeal to someone's emotion because they can hear my voice, they can see my facial expression, they can see my gestures. But when someone cannot do that, then appealing to the emotion will not work. So you need to do a good background of your facts. Look at, for example, the history of family medicine in Africa. Where has it come from? Where is it going? What are the gaps? And give statistics around that. give solid facts around the policy, where has it come, etc. So the thing is, on this point of having sufficient background, you just have to read. There's no shortcut. So don't be a sloth, don't be lazy, you have to read. So I remember this morning, during this morning session, Amanda asked a very important question of who has the time to do that. So for me, what I do, because when you have that knowledge in your head, sometimes it helps you write faster, and it helps you also know what I need to reference to. So I usually say a paper a day keeps ignorance away. So whenever I wake up in the morning, you see there are certain sites I look at, there's certain a certain site I've subscribed to that send me like the latest papers that have come, things like rural and remote health, because I'm also very passionate about rural health as well. So I look at them and just read quickly through some of the papers and also save them in a folder somewhere. So that helps me over time to accumulate the knowledge in my head and also the papers and the background info I need on the issue I would have to write a policy brief on. So you have to have the time. You have to make the time at least to make sure that you have sufficient background on your issue. And if it's at the tip of the fingers, even better. So when I tell you just write a one-pager, it'll just be a matter of pulling up where the evidence is and where the background information is. So you have to do the work, even if you might have to read 50 pages or 100 pages just to write a one-pager. So that's another thing that there's no way around, especially when it comes to good policy briefs. And then the other thing is numbers, numbers, numbers. It's very important that you include statistics to defend your argument. I can't just say there are inadequate family physicians in Africa. I have to give statistics. How many family physicians are there? How many should be there? Why am I saying they're inadequate? Family physicians vis-a-vis the community, vis-a-vis maybe the need in primary healthcare facilities and primary care, which is the first contact. And if, for example, I give an example of Kenya, I'd say 88% of all contact with the healthcare system is at the primary healthcare level, at the dispensaries, at the health centers and community health services. So there I can actually, I'm giving statistics, I'm giving you numbers so that you can actually see the magnitude of the problem and what I'm talking about. So I'm painting a picture in your head. So it's important to have those statistics to defend your argument. Then this one I cannot overemphasize. Keep the main thing the main thing. If I am talking, for example, about inadequacy of family physicians due to not training enough, I need to stick to the issue that you're not training enough. So when I look at policies, HSC, recommendations, it's around how can we train more? So that you don't jump from not training enough family physicians, then the next thing I'm talking about is you're not hiring them. Then the next thing I'm talking about is you're not deploying them. Then I start talking about how they're not well paid, so they're moving out of facilities and moving from rural areas to urban centers. So that is what we are calling a rabbit hole. So I've literally gone down a rabbit hole. By the time I get back to my recommendation, someone is like, wait, what? What was she talking about? Was this issue to do with training? Was it to do with paying doctors? What was it all about? So to avoid that, just focus on your issue and stick to your issue, even in the recommendations, in the research, stick to your issue. If your issue is training, your issue is training. If your issue is compensation, the issue is compensation. If your issue is strictly on, for example, you want to sensitization of the community, for instance, around family medicine, then stick to that, but don't go down the rabbit hole. Then the other nuggets is keep it straight and simple. Because sometimes when you read a lot of papers and publish a lot of papers, sometimes you want to tell people what you know. But at the end of the day, people are not very interested in what you know, the big terms that you know. They just want to know how much you care about that issue and why you should care about it. So use the language that will make them care about the issue. Simple language, nothing complicated. So that because every time you use a technical term, someone will start asking, what is the definition of this term? What does it mean? Because like I remember we were having a discussion the other day around the word comprehensive. When you talk about comprehensiveness and we say a family doctor provides comprehensive care, what do you mean by comprehensive? Because when an insurance tells you comprehensive, then the insurance means it covers you for everything. 100%. But when we say a family doctor provides comprehensive care, it's not the same concept. So instead of using comprehensiveness, you might find another word of saying that you can treat most of the community's illnesses. That one is very simple. You can take care of most of the community's problems or issues, or health issues. So that one at least makes sense to the reader and they understand that makes sense. So, but when you talk about comprehensive care, to you, it might not seem like a technical term, but to someone on the other side, it sounds like a technical term because they're like, what do you mean by this? So just keep it straight and simple and tell people, why should you care about this? Not, I know a lot. Then it's always good to include visuals, because visuals help people paint a picture of your issue in the head. For example, if you look at the very first line where we have 50% and 20% of people, you can see, like, you can paint a picture using that. For example, you can say, out of all the students, for example, in a medical school somewhere, out of the enrollment of maybe 500 residents, only 20 are usually supported for family family medicine, and then use those small figures there to represent. So maybe one of the figures, so when you use these figures to represent something like that, someone can see, yeah, there's actually a very huge disparity there. So you're actually under training. So that will start painting a picture in their head of, yeah, here you have just 2 people, and then here you have 50. I can see how that is quite under training. So it's good to use visuals and charts. Just keep them simple, and then don't overuse them as well. Maybe just a maximum of 2. If you go too far, maybe 3, because remember, you're writing a 1-pager, but make sure that you use the visuals that best represent your issue. In conclusion, you just need to keep your policy brief, targeted, focused, straight and simple, and based on fact, not emotion, because remember, it's a written document and you don't have enough space for you to start trying to use the words that will evoke emotion. So use solid facts. So these are some of the resources that you can read around the issue of policy briefs, preparing them, ECC. And at the end of it all, it's important to do. So I just want to challenge you. Can you write a policy brief, maybe to a policymaker in your setting, telling them about the importance of family medicine in the delivery of PHC for UHC? Because when you watch one, you need to do one, and you need to teach one. And if you hear, you forget. If you see, you remember. If you do, you understand. And then it becomes easier from there. And with that, thank you, everybody. Back to you, Amanda.
Yes, thank you, Mercy. It's a lot to take in, but it's a very vivid example of, amazing piece of work and a delivery over time. Again, colleagues, we have we have time in the we have long enough. So Larry, you have your hand up, please.
Wow, that was spectacular. I'm so curious, Mercy. Could you tell us more about your present role and what you're doing and your pathway to get there?
Okay. All right, Larry. So I'll start with my role in AfroPHC, which is the Africa Forum for Primary Healthcare. I joined AfroPHC when I was doing my residency in Cuba, because at that time I was looking for what I like calling a community of practice. And so I was looking around for organizations that are advancing primary healthcare and family practice in my country, in Africa, and also in the world. So it's at that time that I joined WONCA, and I also joined AfroPHC. And I started joining the AfroPHC workshops and working as a facilitator. Back then, it was Prof. Jabir who was facilitating the workshops. So he would ask if anyone would like to facilitate the breakout groups. So I would act as a facilitator. And then later on, he announced that he wants a group of young people that he'd like to mentor, so that they can take up advocacy in PHC within the region. That is what he called his executive coordinating team. So I joined that team and I started coordinating policy workshops within Afro PHC. By then I had already come back from my residency in Cuba and I was back in Kenya. And so I just continued growing in the organization, taking up more tasks. And then I became deputy executive coordinator. And then finally, around October, Prof. Shabir started the process of transition and stepping down and asked me to step up into my role in Afro PHC. So that is how I came up to my role in the Africa Forum for Primary Healthcare.
Are you in practice?
At the moment, I'm in policy. I was in practice until November. Yeah, so we are now in the process of implementing a primary healthcare strategy for Kenya, 2020-2024. And they felt I was better suited to guide the process rather than the practice. So I'm hoping once I'm able to set up what is called a primary care network, I'll be able to go back to practice as well.
Shabir, please.
Yes, thanks. I mean, literally, Larry, Mercy was a godsend. And I think that she really fitted the bill so well. I was just amazed at the fact that she landed up literally coming along to that simple response, saying, please, would you like to be mentored? You know, it's not just the fact that I mentored, it's the fact that that such amazing people like Mercy can just pop out of nowhere. And I think there are others as well that have emerged, and I've tried to help Mercy to actually learn to mentor people, saying that she's got a great future on the global platform. I think that one of the things that I think would be worth sharing, especially in respect of the policy briefs, I think we actually started with the idea we should be trying to influence politicians. But when we in the space in South Africa found that really we're having a conversation with frontline people, and COVID was a godsend as well, because in a way it helped us with Zoom to actually speak to each other a whole lot more, and people embraced it a whole lot better. So the Zoom itself just allowed us to get communication going. So we had these wonderful workshops virtually across the whole of Africa on a monthly basis, and it was building bridges like never before. And we said, you know, here's amazing stuff, let's get to know each other and let's put it together and build it into a document. When we saw the richness of it, eventually this document became very bulky, and it's not what we wouldn't call that a brief. And when we were given a grant to actually go through this process, and we said, you know, what is it really, and who is it for? And we realized, no, this document is more a collation of all the various discussions in an order that speaks and makes sense to us as the primary care providers. But we will need to build consensus on what that says, and then later we can break it out into policy briefs as we define it and further the process. So I think it is more what we did, but I think it's been very useful, and I think it will become a very big place to help form people's ideas. A lot of people have actually come around to saying, I like what Afro PHC and WONCA are doing because of that document and the nature of the discussion. So it's not quite the policy brief. So as Mercy said, it's more a policy framework. I think Sanka wants to speak. Thanks.
Yeah. Sorry, Sanka, please.
You're on mute. Okay.
Not
Thanks.
now.
Thank you, Shabir and Mercy, and congratulations. I mean, excellent work. And especially about Mercy, because as a young doctor, I'm really proud of her work. And especially in all our webinars, we were talking about examples of policy advocacy work. And I'm happy that Mercy brought not only some examples, but she also talked about the principles and sort of, you know, basics of advocacy and policy work and how to present them. So that is excellent. I mean, that is very important, I think, because most of the time we were assuming that people know that how to present these, how to go ahead with policy and advocacy. So I mean, bringing some essence and examples as well as its basics is very important. I think we have only a few people, but I'm sure that this would have been benefited a lot. The people who have much knowledge and experience in advocacy. So I think this is, I'm sure that this was recorded. Is that so, Shabir?
Yeah.
Great. So I'm sure that this will benefit a lot. Thank you.
Thank you. And another point, April made a joke in the chat, but I mean about the skill of writing a policy brief. I did say this morning in the webinar, but I think worth saying again that I think capacity for, you know, it's one thing to learn the skills of how to talk with somebody about the message. It's another thing to learn the skill of how to find evidence that may be relevant or to accumulate it. And then it's another set of skills. And most family doctors, unless they have a university setting or a professional body setting or an organizational setting, won't have the time to do some, or won't, you know, have the time to do it easily. Having said that, April has asked Mercy and Shabir if you can share some examples of a policy document. And so also when we load up the website, if there is one that could be publicly used as an example, just to give people some sense of what a, you know, good briefing really looks like at the end product. I can see that people would like that, and maybe then it becomes something they can, you know, develop themselves. And also, although we've already finished putting in our workshops for WONCA World and WONCA regional meetings, you know, running a workshop on writing a policy briefing might also be nice. So thank you, April and Sanka, great idea. Mercy, you wanted to comment back?
Yes, I think I can find I can try and see some which are usable, because like most of the ones that I've written so far are for my county government. Because like I mentioned, they called me on board to really guide the process. So I'll try and find those ones which at least can be usable in the public domain. Then the other one is, for example, for me, especially in my current role, which is heading a Directorate of Primary Healthcare, which has family health amongst other things in it. I'm usually called upon a lot, especially by what we call the CC, which is the County Executive Member for Health, which is like a minister at the county level. And he's always telling me, I have a meeting at 6:30 with the governor. I need you in that meeting and come with a brief on this. That's how it works.
Well, that speaks to the skill. And I think that
yeah, so it
the
kind
point,
of makes
Amanda,
you
is that it mustn't be sort of mystified. I want to just say, see if I quickly can just intervene. I think the policy document itself, the policy framework, is actually a series of policy briefs, and we've kept them deliberately small, so they're almost a page, a little bit more, but they're easy to read. They speak to the evidence, and they come with a position. It's not exactly rocket science, and a little bit of practice. And I think your idea of having a workshop is an excellent one. I'm sure that we as a group can facilitate such.
And maybe some examples. April, please.
Thank you, Amanda. And again, my appreciations for Shabir and Mercy for everything you have done for there. I'd like to point out on the last point, which is data-driven but not emotionals. So I do agree on paper it should be like that, but on delivering your message with the human that you are having conversations with, isn't the emotions element play a role, especially when we are talking about human life, not necessarily a quantitative base, but one life is matter. And then when we're talking about the family medicine and primary healthcare, where community is at the center, what's your point on that? I mean, because from the example Shabir certainly point out how he stay focused on engaging with the community and the people that have power and influence, which is emotional aspects. So how to deliver that? Thank you.
Okay, Mercy, you still have your hand up. Did you want to come back again?
Yeah, I just want to respond to what April is talking
Please.
about. Yeah, when it comes to when you're writing is different because emotions are based on a lot of things. Like if someone can hear the tone of your voice, see pictures, etc., it's usually better to use emotions. So when you're advocating to someone face to face, when you're doing maybe a presentation, emotion comes in. And how do you tag at emotion? Personally, I like beginning with a story. Just a really short story. It could be a personal story that talks about my issue, or it could be another story that I witnessed somewhere that talks to my issue. So that story is to bring out that emotional part so that when you're talking to them about the issue, you've already tagged onto their emotion. So when you're talking to someone face to face, when they can see you, when they can hear you, emotion is always a good thing to hook. So my advice on that was to always have a story that, not a very long one. Don't give a very long story, then go down rabbit holes. Just a short, maybe 5-minute opener. And the good thing is maybe you can practice like writing it, reading it, so that it's always at the tip of your fingers. So when you start, it comes naturally. You know where to pause. You know where to look across the room. So that would be my advice when it comes to when you're talking to someone face to face and doing advocacy face to face. Thank you.
Thank you.
Thank you, Mercy.
Perhaps I can
Yeah.
just quickly comment, Amanda. It's just to say that the policy briefing is just one way of communicating. And it's very powerful because when politicians sit and have things on paper in their space, they need to see something that passes the bureaucrats. And that bureaucrats will not put things that are not evidence-based. And I think when it doesn't stop one from actually in a policy briefing to actually quote instances or use statistics in a particular way or give anecdotal instances, etc., to demonstrate a point. But it shouldn't be, please help us, or everybody's dying. You should not be unsupported. That's just good academic writing. And because it's directed at people who are looking at rigor, you need to pass that. There are, obviously you've talked about presentation or talking. You always got to think, how you're talking to the other person, whether it's a committee worker or a minister or whatever. And like Mercy says, story is really great. And using that emotion, which we have as frontline to show an instance, is really powerful, and use it. Obviously, the press briefing, the policy briefing gets in, and then you have that opportunity to speak when you invite. But I think there is another document, another one that we have talked of in Afro-PHC, is a press statement. There, it's a different type of approach. And this is basically something that you want to report on, and press releases are really powerful because it's free marketing. And you need to craft it so that it is something that a journalist writes, and it has a certain format. And if you do it, you can actually be very successful in getting simple stories into the public's domain, and you can make it say what you want it to say. And most journalists are quite lazy. If they're finding something really good that does their work, they'll take it and use it. And you need to know how to write that. So that's another tool that you can look at. There are other things that we can think about in terms of skills, but just to note that.
Yeah. I also have two things that I have noticed that are relevant to this. One is relationships. So example, WONCA executive and the staff team world level do not have so much capacity, but we've worked very, very hard over many tenures to build up relationships with different people in WHO. And I know that colleagues in their countries will try to do the same with politicians or with civil servants, so that if you have a document or if you have an idea or if you come in, they may speak to you and they may help you and they may give you ideas back and so on. So relationships is one thing, and then again, capacity is another, because all that takes some time. And certainly my own college, I know, had, you know, over the last 20 years, has invested quite a lot of money into having staff who will do write policy briefings and press statements and develop those relationships and help then the leaders to get a good media coverage or whatever it is. So I think, again, if we are leaders in our national settings, it's worth very much thinking about, you know, how do we find a mercy? You know, how do we build up that person or those people who can help us with those things so that we have the front end, because, you know, that seems to help as well.
Thank you, Mercy, Sabir, and Amanda. Really insightful and fruitful.
Great. Anybody else have anything else they would like to raise? I know we're all busy people. Shabir and I have discussed, you know, we put 2 hours, but hour and a half is probably plenty. I can see Bob Phillips joined us late, but he's on the page now. Hi, Bob. Nice to see you.
Good to see you too.
Yeah, we recorded it, and hopefully we'll be able to put this onto the portal so people can see it. Larry, you flagged something again, yeah?
Good.
Yeah,
and Scott. Larry and then Scott.
I want to ask you on my screen here to refute or confirm one of the things I think I learned today from this webinar. All across the world, is there just not an agreed, sanctioned role for the family doctor in healthcare systems? Do people? One of you said they don't know.
Say that again, Larry. Sorry.
I'm sorry if I'm not coming through. I'm asking for your opinions about whether or not in your situations there is a defined, expected, sanctioned role for the family doctor. I heard several comments that suggest that has to be explained. And the way the family doctor works in a team and the way the family doctor works within the community and with the community, that this is something that has to be learned. So I'm just wondering if you think that we share across our countries a lack of understanding what family medicine is and what family doctors are good for.
Well, I'm going to answer that, having been WONCA president. I'm going to take the first stab, because what I learned during that role was that many countries didn't yet have a fully formed, accepted role and place and training in their health system for family medicine. Many countries were still making that journey. And even my own country, where we have had, you know, specialty training for 30 years, and it's a very clear role within our National Health Service, still all the time the exact role and the interface with the team and who does what and how they do it keeps shifting. I guess that's probably true in many health systems, but I think that many countries are still just on that journey, Larry, and some people in a country will have got it, but many people, because they didn't grow up with that and they didn't train with that and they didn't have that, you know, background historically, are still trying to understand what it means. I've got Scott, please, with your hand up.
Yeah, good morning, or at least this morning here in California. Hi, Shabir and Amanda. We've met a variety of times over the years. I used to work with Prima Ahmed, and Thank you, Mercy, for your really great presentation. I kind of know a little bit about her journey because she went to ILAM, the Cuban medical school for outsiders. And I still teach at a variety of residencies for family medicine in California. And we've had a number of ILAM grads, Americans that train down in Cuba as well. And they're really excellent clinicians. They're really well steeped in primary healthcare, community medicine. And of course, that's what she's now applying in Kenya. So her presentation was really great. I'm glad to see someone like her who's younger than Shabir and I and Amanda, doesn't have any gray hair yet. So that's really encouraging. I guess my only comment, because when I first started with some of the Prima FAMED and the Sub-Saharan programs, it was back in 2006 and 2007. I'm a little disappointed that we're still talking about some of the same things that we were back then. And I see that there's still movement. One of the reasons I was kind of lurking on this meeting, Shabir, is that I really want to come to the WONCA thing in Sydney this year to kind of reconnect, because I've been out of global health for about 12 years or so, just because I've been doing mostly domestic stuff. But again, this is a really great program. The presentations are really good. I'm encouraged that, you guys are keeping with it, particularly in the Afro-PHC community and in South Africa. So nice to see everybody I've seen before, and thanks for the presentations.
Thank you, Scott. That's nice. Well, yes, hopefully some of us will be in Sydney, and we have put in some dedicated workshops from this special interest group, and we hope they will be there. And so who knows? Mercy, I'm going to actually invite Mercy and Shabir to say a few closing words anyway. Nobody else has got their hands up. So Mercy, would you like to come back? And then I'll go to Shabir.
Thank you, Amanda, and thank you, Scott. Primary healthcare has really matured in Cuba, and that's why. And just to answer the question on the issue of the role of the family doctor, the truth is we have not agreed, because people have 15 million concepts of what a family physician should do, mostly subjective. And because nobody has strongly come out and brought about a document and said, this is the agreed role of a family doctor. So people are left to those subjective sentiments. And I will always cross-reference with my experience in Cuba, where the family doctor's role has always been clear. Everything they have implemented is along the sentiments that were there in the Alma Ata, word for word. So for them, they just went and took policy and went and took, the family doctor then was described as having to do this. And they went and put it in their system, and that has been the role throughout. So I think there is room for us to come out and really say and agree, what is the place of the family doctor? Because I usually say, like for other specialists, you don't say what is the place of a surgeon. Everybody knows what a surgeon does. Everybody knows where a surgeon should be. So why not the same for a family doctor? Because we cannot be everything everywhere for everyone all the time. That is not correct. So I think there is room for us to get that consensus once and for all, and come out and work even with agencies like the WHO and say, this is the role of the family doctor. So when you're developing your HRH competencies and ETC framework, remember to say the way you say a surgeon works in theater doing surgeries, then a family doctor works here doing that. I think that would be a very important thing, so that we stop leaving people to their devices, because like they say, nature hates a vacuum. There's a vacuum there and people are filling it with anything that they feel should be filled there. And yeah, thank you for that. Thank you so much, everyone. So let's keep advocating for family practice, because it is the way to go.
And one thing, Mercy, I will say, thank God we have people coming from the next generation, including other colleagues on this call, because, of course, I feel like we produced that definition for WONCA. We've taken it to WHO. We tried to get it into the Astana Declaration. And so you do have to be very persistent. And sometimes, other people try as well, and that really helps. So I think. Shabir.
Yeah, no, thanks. Just to mention that Innocent Besige will be presenting in on Afro-PHC in a workshop in Sydney. So just as a note, I think we can actually, if Innocent's okay, we can actually include it as one of the, as an activity of the SIG. Mercy, if you can just ask him that, and I'll just inform the organizers that his workshop is also part of the SIG. The question I think that you ask about the understanding, Larry, whilst we think it is universal, it's actually not. And I give you a problem. In the bylaws of the WONCA, there isn't actually a definition in the bylaws of who a family doctor is, what family medicine is, or what a family physician is. In fact, it only speaks to, it doesn't even speak to a medical practitioner. It assumes that's the same thing globally. So I think there's some serious issues, and we raised it as a bylaws committee in the previous term, that these are challenges, and we suggested that this be dealt with. Unfortunately, in the present term, it seems to have been subsumed into a process of strategic discussion, and I think it's gotten all sorts of issues around it. The chair, I think, will be looking at it, but I mean, we've spent literally a year and a half almost just talking about creating a strategy and dealing with some of these issues. So I think there's some serious challenges in really moving along in addressing lots of these issues. And I'm hoping that, I think that the president will be talking to some of these issues at the Sydney meeting. And I think this is really overdue and should be addressed. What is it and how can we speak to it? I think there's a lot of intimations that we do speak to these things, but there's no official document actually putting that out that is public and on WONCA's website, nothing like that. So in terms of going forward, I think that we're very interested in advancing the idea of the SIG, and I think we want to try and create a small executive. If people are interested, you're welcome to join it. I do think that there's a great opportunity. We've talked this morning about a topic like, WHO engagements. Is there any lessons to learn in various people's experience with engagement of WHO? I think this will be very useful for people. There's also, I think, a lot of capacity in the UK and in particular in USA in terms of engaging with resources. And I think we would really find it useful if these three countries, perhaps one or two other, were to share their experiences. And I think the US has got a lot of stuff that it does that I think is very worthwhile sharing more globally about how it does advocacy and what its pros and cons and lessons to learn are. The third thing I just want to mention is that in this discussion, Amanda has raised the question of resources. And I would be very interested if we could, I'm on the executive, and I mean, after this discussion, I've actually wondered, can we not go and motivate for additional fees by member organizations for the particular purpose of setting up that kind of capacity? I know that, organizations like the Academy in the US feel that there needs to be a lot more stronger focus on policy. But the capacity in the current executive is just nominal, and even in the secretariat. And this would be a very important motivation to say, let's increase the fees, but let's dedicate those kinds of things to capacity that is very much more clearer and that has outcomes than just simply adding to the budgets of WONCA. So I just think that whether that's a good idea or not, but I personally, I think it's a worthwhile consideration that WONCA is looking at raising fees, and this could be a way to motivate for the fees as well. So just a thought around that. But thank you all very much for the attendance and for the contributions. Great stuff. And thank you, Amanda.
I think we have to say that one was said in a personal capacity, isn't it?
Yeah.
Thank you very much to our speakers and to all the colleagues who came, and for your work as well. And we wish you well, especially those of us in troubled places, Austin. And we will all be in touch soon. Thank you very much.
Bye-bye, everyone.
Thank you very much.
Thank
Bye.
you, everyone. Bye-bye.
Bye.
Bye.
Bye-bye.
Bye.
Thank you.